Hello, everyone, and welcome to ZAVA's Lunch and Learn today, which is on STIQ Day, and we'll be talking about STIs, sexually transmitted infections. I hope you'll appreciate I can't see you. If you have any concerns, please let us know, and we'll address them. Any issues with sound or anything. So I'll show you a bit about what I'm going to talk about. The agenda for the talk is to discuss what STIQ Day is, what it means, and why it's on today. I'll give you some fun facts about STI history. I'll talk about some of the most common sexually transmitted infections, what they are, how they present, and how we treat them. I'll then go into a bit about the changing landscape of STIs, so how things are changing in that field. I'll touch on how COVID may have changed things last year and how it may have affected both testing and diagnoses in 2020. I'll then talk about what we offer and what we do at ZAVA, and I'll give you a couple of interesting bits about COVID-specific advice from various people around sex. What is STIQ Day? As I said, I myself hadn't really heard of it until fairly recently, but it's STIQ, so Questions Day. It launched a few years ago to get people to think about their sexual health a bit more. And it's fallen on, or it's been decided to be on the 14th of January this year. And the reason for that is because it's 2 weeks after New Year's Eve. So if there were anyone who had a bit of fun over the Christmas period, over New Year's Eve, and they needed to get tested, then 2 weeks later is the optimum time, because it can take most STIs up to 2 weeks to become detectable. And it's just to get you to think about checking for these in a more structured way. It's also about a month before Valentine's Day, so again, if anyone is thinking of going on a date or a hookup nearer the time, if we're allowed, then you want to make sure that you're STI free. It's really important to get tested, and this message is for everyone. A lot of people may think that because they don't have a lot of sex, they're not at risk, but just one unprotected encounter could put you at risk of catching an STI. So it's really important to spread the word and get tested. Right, a little bit of history for you. In 1494, there was a huge European outbreak of syphilis. It's thought to have started from French troops who were besieging Naples in the Italian War of 1494 to 1498. And it spread from there, and eventually it's thought to have killed over 5 million people across Europe in that wave. There is an American historian called Jared Diamond who has described what syphilis was like at the time. And he said that when syphilis was first definitely recorded in Europe in 1495, its pustules often covered the body from the head to the knees, caused flesh to fall from people's faces, and led to death within a few months. It's a pretty gruesome picture. This is thought to have been the way that syphilis presented back then, but it may have mutated or changed, or the way that we react to it may have changed, so that several years later there are other documented recordings of syphilis, which is more, which looks more like the syphilis we know today. It's thought to have been contracted by sailors who were traveling from Western Europe to the Americas on the Columbian Exchange. So after Christopher Columbus traveled to the Americas, it's thought, one theory is that it was passed on from there and came to the Old World. Gonorrhea is another STI that's steeped in a bit of history. It's also called the clap, and it's first recorded at least up to 700 years ago. It's thought to be associated with a district in Paris, formerly known as Le Clapier, which was known for its prostitutes. So one theory is that the reason why it's called the clap is because of its association with this district. Another theory is that because gonorrhea can cause a lot of discomfort in the genitals and it can cause pus, there was a trend at some point in the past for men to try to expel the infection and treat it by clapping their penis in between two very stiff boards, or sometimes they'd use boat paddles, very hard to try and get it all out. So please don't do it at home, but that might be another reason why it's called the clap. Another interesting fact is that when Captain Cook went to Tahiti in the 1700s, they had to reschedule their return departure because his crewmen were so ill that they couldn't leave on time, and there was a combination of gonorrhea, syphilis, and TB. But it really wasn't until the 20th century when we had developed effective antibiotics, when we got a handle on STIs. So let's start with some of the common ones. Syphilis is a bacterial infection caused by the bacteria Treponema pallidum. It is a spirochete, which, as its name suggests, is spiral under an electron microscope, as you can see in that picture there. There are three main stages of syphilis. Primary syphilis is the presentation that is seen usually very soon after infection. It is typically thought to present with a canker, which is usually, but not always, one firm, painless skin ulcer, and that tends to be on the penis or in the vagina somewhere. It doesn't always present that way, but it's typically thought to be that. If you leave it untreated, it will last for 3 to 6 weeks and it will go on its own. Now, if you didn't get treated or didn't get tested after your primary syphilis and you didn't get treatment, you could then develop secondary syphilis. And this happens a few weeks later. And it's known as a great mimicker because a lot of the symptoms that present through secondary syphilis are overlap with other conditions. But it typically will present with a rash and a fever, and you could get a sore throat and headache and other symptoms like that. So if you're sexually active, you've perhaps had risky sex, you haven't had an STI check recently, and you become unwell, really important to do a syphilis test. Because if you left that untreated, then many years down the line, you could develop tertiary syphilis. And this can occur sometimes over 40 years later. It can present with one of 3 different types of tertiary syphilis, either gummatous, neurosyphilis, or cardiovascular. So gummatous is rubbery lumps that can be found in different organs of the body, but most dramatically on the skin. And there's a picture there of a model or a mold of a head of a person with tertiary syphilis, gummatous, in a museum in Paris. And the treatment for any kind of syphilis or any stages, intramuscular injections of penicillin. Now, it's important to note that if you get tertiary syphilis, then the penicillin treatment is really to prevent further deterioration. It's not really going to reverse the damage that's already been done. So again, important to get tested and get treated. Gonorrhea is a bacterial infection caused by Neisseria gonorrhea. In most men and about half of women, you will have symptoms, but that leaves the rest without. So about 1 in 10 men and the other half of women will not have any symptoms. If you do develop symptoms, it's usually a discharge, which is usually pussy. It can be thick and smelly. It can be yellow and green. And you can usually get pain when you go to the toilet, among other symptoms. Rectal, throat, and eye gonorrhea are quite common as well. Obviously, it depends what kind of sex you're involved in, but wherever you have contact with sexual fluid, if you've got mucous membrane there, if you've got the kind of tissue that will get infected easily, then you can get a localized infection there. So you may well get symptoms elsewhere. The treatment is usually through a combination of antibiotic injections and oral antibiotics. Now, the problem with gonorrhea is that we have got to the stage where we're finding a lot of antibiotic-resistant strains of gonorrhea. And the reason why treating gonorrhea is a bit tricky is that different parts of the country and different parts of the world will have different strains of gonorrhea that are resistant to different antibiotics. So the gonorrhea that I might have in London may well be different to the one I get in Glasgow and need different treatment. So it's really important that, again, really important to get tested, but really important for the lab to liaise with the local microbiologist to decide which antibiotics to give you. There is worryingly a strain of gonorrhea which is treatment resistant called super gonorrhea by some outlets, which seems to be resistant to all the antibiotics we have. So the moral of the story is to get tested regularly, to use condoms when you can, get tested regularly, get the correct treatment, take the treatment for the correct amount of time to avoid developing these resistant strains. Chlamydia is one of the most common STIs out there. It's a bacterial infection caused by Chlamydia trachomatis. And as you can see in that diagram, 5 in 10 men who've been infected don't have any symptoms. And most women won't either. If there are symptoms, there may be a discharge. The discharge tends to be less pussy and less thick than gonorrhea, but it's not always. And there is often pain when you go to the toilet, among other symptoms. Again, just like gonorrhea, you can get chlamydia in different parts of the body, depending on what kind of sex you're involved in and participating. The treatment is simpler than gonorrhea. There seems to be less antibiotic resistance to chlamydia for now, and it tends to be across the board doxycycline, at least in the UK anyway. These are capsules that you take for a week, and if you take it properly, and take the full course, it will treat the infection. Now, the problem with the infections that may not present with symptoms is that you won't necessarily know that you need to get tested and get treatment, which means that you'll be harboring an infection for potentially years to come. And if left untreated, things like chlamydia can cause conditions such as pelvic inflammatory disease, and that will lead on to fertility problems. Now, pelvic inflammatory disease, or PID, is where the infection and the associated inflammation will travel from the lower genital tract, from the vagina, into the womb, the uterus, further in, and it will cause scarring and inflammation, especially in the fallopian tubes, which is where the eggs are released and come down into the womb, and that can cause problems with fertility down the line. Obviously, acutely, it will cause a lot of illness and symptoms itself. And a similar thing can happen in men with testicular infection. Genital warts, another delightful topic. You can see in the pictures there are two different looking lesions, but they're both warts. The one on the right is more spiky, and that's kind of a really stereotypical presentation of a wart. It's obvious what it is to us anyway. And the other one, they kind of look a bit like stuck on bits of chewed food or Cocoa Pops or whatever. At least that's how we were taught at medical school, how to diagnose things like warts and seborrheic warts. But anyway, these are caused by a virus called human papillomavirus, HPV, as it's more commonly known. There are over 100 different types of HPV, and over 40 of them infect the anogenital area. But the most common ones that cause warts, visible warts, are type 6 and 11. Over 75% of sexually active adults have been infected with at least one type of HPV at some point in their lives. So it's incredibly common, but most don't develop visible warts. So most of us have probably been infected with at least one type of these viruses, but most of us won't know about it. However, the infection might show up, especially in women, if you go for a cervical smear. And this is called a subclinical infection. So you have an infection on a test, but you don't have any symptoms or visible signs of it. The way that HPV works and works its way into a wart is that the virus gets incorporated into the skin cells, and it stimulates them to proliferate or to grow, and it causes this lump that is seen as a wart. Some strains of HPV can cause cancer, as we know, anogenital cancer, and these don't tend to present as warts. So they're different strains that don't tend to show up as warts, but they will cause cancer. And it's why it's really important, apart from STI testing, that women go for their cervical screening on a regular basis, because it will pick up signs of infection and then signs of change caused by that infection. But going back to standard genital wart treatment, the treatment is pedophylotoxin, which is more commonly known as Condylin or Watercon, these are the brand names, or imiquimod, which is Aldara, and we provide both of these at ZAVA. So these are first-line treatments. There are other treatments, but this is what we tend to use and works in most cases. Genital herpes is caused by a viral infection called herpes simplex. Again, another one of the most common STIs, with up to 23% of adults in the UK and US having antibodies to type 2 herpes simplex. So up to a quarter of adults having been exposed to one of the types of HSV. These tend to present as a cluster of painful vesicles or blisters with a clear fluid in them. That's what a vesicle is. And there are two types, as I've mentioned, types 1 and 2, and these can cause oral, genital, or ocular ulcers. Ocular is another word for eye ulcers. So again, anywhere with a soft tissue we call mucous membrane. You tend to get a primary outbreak soon after infection. So it's usually soon after infection, and it's usually the most severe outbreak you'll ever have. The problem with HSV is that is with the word usually. There are lots of patients who we see, and lots of patients I've seen before, who have come to us with what sounds like a first outbreak, but when you take a history, their last risky encounter was several years ago or months ago. So it's not necessarily always soon after your sexual encounter, and it can sometimes cause concern over issues around fidelity and who gave me what. But it's really important to stress that you really can't tell when an STI was transmitted, and it's really important to have those serious but difficult conversations with your partner and have an honest conversation. And it's important to realize that it doesn't always or necessarily mean that there has been any infidelity. So after the primary episode, the herpes simplex virus lives in what we call a latent state in the spinal dorsal root nerves. Now, these are the base of the nerves that come out from the spinal column and supply sensation to the skin. So the virus breaks out initially, and then it sort of lies dormant at the base of these nerves near your spinal column in that one nerve. And over the course of your life, it can reactivate at any time. And when it reactivates, it will travel back up that nerve and present as vesicles along where that nerve would normally supply your skin. So that's why it tends to be in the same area. Your reactivations will usually be less often and less severe as time goes on. And the treatment is with antivirals, for example, acyclovir. Now, these will help to reduce the severity of the outbreak and the length of time that the outbreak is there, but it won't cure you of the virus. You will always have the virus there, but you can take suppression, which is where you take these antivirals on a regular basis to reduce the number of times that you get reactivations. There's a fun fact that I came across as I was writing this presentation, and that is something called scrumpox. It's a cluster of blisters on one cheek in a rugby player, which I've actually never seen before or heard of before, but interesting to know that rugby players can also be affected as part of the scrum. Trichomoniasis, this is another common infection. It's a parasitic infection caused by Trichomonas vaginalis, and it can cause similar symptoms. I'm going to rush a bit because I can see that time may be running out. And treatment is with antibiotics like metronidazole, which we also provide as ZAVA. So the changing landscape of STIs. This is information from one of my update courses, but also a report by Public Health England in 2017, which shows some worrying things. These included that the diagnoses of syphilis have increased by 148% since 2008, and are now as high as those in 1949. Diagnoses of gonorrhea have increased by 22% since the previous year, especially worrying considering the emergence of supergonorrhea and so on. Chlamydia testing has fallen by 61% since 2015, when this report came out, and that reflected the reduction in service provision in the public sector for testing with budget cuts and so on. But good news was that diagnoses of genital warts in school girls have reduced by 90% since 2009 due to the HPV vaccination program. Rates of STIs remain highest in young straight people, Black ethnic minorities, and in men who have sex with men. And in 2017, there were over 400,000 new STI diagnoses made at clinics, and the highest of these was of chlamydia. The conclusion was that we needed better open access sexual health services, particularly targeting those at-risk groups. We needed increased promotion of chlamydia screening, and we needed better sex education at school. We should continue the HPV vaccination program in young girls and men who have sex with men, and we should be promoting condoms much more through media campaigns and through local services. So how has COVID changed things in 2020? Well, unsurprisingly, it led to a reduction in testing. There is a provisional Public Health England report from January to September, which has described how between March and May last year, there was a reduction in consultations undertaken by specialist services, testing for viral hepatitis, HIV, and STIs in general. There was a reduction in vaccination of men who have sex with men against HPV, Hep B, and Hep A. There was a reduction in diagnoses of viral hepatitis and HIV and STIs, and a reduction in starting treatment for hepatitis C. Now, the worrying thing about this is that if you were someone who may have been at risk at the start of the year, maybe January, February, December, January, February, and you wanted to or needed to get tested during this time, and then we had the lockdown, you may have either forgotten about it, delayed it, or anything else, and be unaware of an infection that needs to be tested for or treated for. There was a resurgence of testing and diagnosis from June onwards, but still at much lower levels than 2019. What they did describe was an innovation in service delivery using online or telecommunications that's happened at pace during 2020. But that conditions like hepatitis C, HIV, and other STIs predominantly affect socially disadvantaged or marginalized groups. And of particular concern, hepatitis C testing through traditional venues may not have reached those in need. So it's interesting to look at whether there's any role that we as a company or we as a healthcare body can play in tackling these inequalities. Is this lockdown, is this new normal our chance to radically reduce the rates of sexually transmitted infections? We're staying at home, we're hopefully having less risky sex. Should we be getting tested? Yes, we should. And treated? Yes, we should, before we resume normal activities. And will that make a huge difference to ongoing rates of STIs? I think it will, and I think that's why it's really important to keep spreading the message, especially with this STIQ Day. So what do we do at ZAVA? We do all the first-line STI tests that you need to do. And we do some more that you don't necessarily routinely get first-line through the NHS. So we do testing for HIV, syphilis, Hep B and C. we test for chlamydia and gonorrhea, and we test in 3 different sites as necessary, so in the mouth, in the bum, and in the genitals. We test for HPV, herpes simplex, trichomonas, mycoplasma, ureaplasma, and Gardnerella. These tests are all free for ZAVA employees, so please do get tested. For the public, they start from $27.99 on ZAVA UK, and the cost goes up. But the cost includes packaging equipment, return delivery, lab processing, doctor review, messaging. But most importantly, perhaps, it includes free confidential doctor advice and follow-up before and after the test, as much as you need to and as much as you want to through your account. So I think, you know, it is a service that you wouldn't necessarily get as easily or as quickly or as well elsewhere. We also treat some of the STIs, so we treat chlamydia, herpes, warts, trichomoniasis, and we provide pre-exposure prophylaxis for HIV. And lastly, just to end just in time, there's a couple of bits of information that were published last year during our COVID special times about sex. So the Terence Higgins Trust said that your best sexual partner is yourself, and they published advice in August suggesting people avoid kissing, wear a face covering, and choose positions that aren't face-to-face during sex to reduce the rate of STIs. And they said that your best sexual partner during the pandemic is yourself or someone within your household. Another interesting bit of information and advice came from the British Columbia Centre for Disease Control in Canada. And in one of the sections where they talk about advice about sex, they advise using barriers like walls, and they specifically give an example of glory holes that allow for sexual contact but prevent close face-to-face contact. I thought that was a funny end to the presentation. Anyway, thank you very much. I hope you've learned something. I hope it's been informative. And the main message is, if you need to get tested, please do get tested, and please spread the word for everyone else to do so as well. We can make a difference.